The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Hello, welcome back to Knowledgeable Provider. I'm Jody Marks. I've been really curious about this new medicine that just came out for treatment of gastric-related problems. I try to keep up with research articles and not just learn about new medicines from the drug reps, but on this one, when the rep came to our office to tell us about it, that was the first time I'd really heard anything about it. So I've been curious to learn more about how it works. To be very honest with you, when the drug reps show up, I'm kind of trying to escape from them as quickly as possible. But I am interested in learning about new medications that come out, of course. So this particular drug is called vonoprazan. The brand name is Voquenza. It was approved by the FDA in November of last year, and they're marketing it as a sort of an alternative to PPI therapy. So PPIs, of course, are the things like omeprazole and esomeprazole and lansoprazole, brand names Prilosec, Nexium, Prevacid. And the way the rep explained the mechanism of action to us was a little bit vague. He kind of said, it just bounces from one receptor to another instead of just staying on one, talking about its action on the quote-unquote proton pump. So I was thinking, how's that really different from a PPI? Like, it's this new medicine that's an alternative to a proton pump inhibitor, and yet it works by inhibiting the proton pump. So right off the bat, I feel like the classification of it is a little bit, maybe not misleading, but counterintuitive, because they say, it's a novel medication, it's a new mechanism, but you still are inhibiting the proton pump. So I feel like it's a little bit of splitting hairs here. But the actual class of the medication is PCAB, which stands for Potassium-Competitive Acid Blocker. And it ultimately, at least in my mind, has the same effect as a proton pump inhibitor. It's just turning off the little pumps that generate the acid in your stomach. But there are a few little reasons why it's different. The way that both of these medications work is by binding to this little pump that exchanges hydrogen for potassium in order to secrete acid. And this happens in what's called the secretory canaliculus inside the parietal cells of the stomach. But these little things are not like primed and ready to go all the time. They're kind of stored inside the cell away from this channel where they do their secreting. And when they're needed, they're moved into position and activated. So in order for drugs to get to them, they have to be in position. So it's sort of like any kind of blade or tool that you keep a sheath on for safety, right? You have to pull the sheath off in order to actually use the tool. So that's similar with these little pumps. They're protected. They're inside the cell away from the outside. The drug can't really get to them to inhibit them until they're locked into place and ready to work. So the interesting thing about the PPIs, proton pump inhibitors, the older medications, is that in order for them to be turned into their active phase that actually inhibits the proton pump, they have to be exposed to acid. So before those drugs can work at all, they have to be turned on by the acid in the stomach. That's why it kind of matters how close you take them to when you're going to eat. And that is not a characteristic of this new medicine, the vonoprazan. It's already in its active form. It doesn't require acid to be activated, so it's not as critical that you take it any certain time around when you're going to eat. You don't have to take it with food, without food. It doesn't really matter. And the funny thing about the PPIs is that they require acid to be activated, but they're also unstable in acid. And so some of the drug actually gets inactivated by the acid that it needs to activate itself in the first place. And that's another characteristic that's not true of the new medication, the vonoprazan. It's very stable in acid. So it seems like it's just more reliable, more consistent in its ability to make it to its target. And everything you read about it always points out how the binding of the new medication, the vonoprazan, to, I'm going to call it the proton pump. The actual name is the hydrogen potassium ATPase. But the way the vonoprazan binds to that is reversible, whereas the way a proton pump inhibitor binds to it is irreversible. And you can find the explanation for why that is about covalent bonds and blah, blah, blah. I'm terrible at chemistry, so I'm not even going to try to explain all that. What I'm curious about is why that's better, and I can't find an answer to that really. You would think if it's reversible, then maybe that means they let go and, take the afternoon off and then get back on there next time they're needed or something, but it doesn't seem like that's how it works. And actually, the time that they stay on the proton pump is way longer than the proton pump inhibitor. So I don't know that that's an advantage, or maybe it's just a difference that they point out. But it seems like this new medication does result in a lot longer lasting acid control. With PPIs, there's still a problem with people taking the medication in the morning and then still having issues with acid overnight. I know with a lot of my patients, I'll have them take a PPI in the morning, and then if they need something else in the evening, I'll have them take an H2 blocker, a famotidine. Or sometimes people will just take 2 doses of the PPI, one in the morning, one at night. But it seems like this new medication does control the acid for a lot longer, and you don't have the same issue with nighttime reflux. So it seems like that's really the main advantage of this over a PPI. The indications it's approved for are erosive esophagitis, non-erosive gastroesophageal reflux disease, and H. pylori. So it seems like it's definitely better than the PPIs in the treatment of H. pylori. Of course, when you're treating that, you have the patient on 2 antibiotics and a PPI, because it's really important to elevate the pH inside the GI tract in order to get rid of the H. pylori. And it seems like the new class of medication does that a lot better than the PPIs. They've been studying these medicines for a long time. Of course, anytime something seems new, that means it's actually been around for like 10 years. And the first one of these that came out and was approved for use in Japan was way back in 2015. So these have been around for a while. So I found a systematic review and meta-analysis from the Journal of Gastroenterology and Hepatology from back in 2022 by Simadibrata et al. They concluded that the vonoprazan is superior to PPI for first-line treatment of H. pylori as well as erosive esophagitis, but non-inferior in other situations. So in patients with H. pylori or torn up esophaguses, it seems like this would be a better first choice for just regular acid reflux control. In practice, it seems like maybe this new medicine doesn't work that much better than the PPIs. There aren't really any major contraindications. You do have to be careful if you have renal or hepatic impairment. The renal dosing situation listed in Hippocrates is kind of weird. If you're using it for erosive esophagitis and their GFR is under 30, you use the lower dose, the 10 milligram dose, as opposed to the 20 milligram. If you're using it for H. pylori and their GFR is under 30, you're not supposed to use it at all. But if you're using it for any other indication, the only other indication would be non-erosive symptomatic GERD, you don't have to adjust it for renal function. So that's kind of strange. I don't really get why that would be. And the same is actually true for the hepatic dosing. If you're using it for symptomatic non-erosive GERD, you don't have to adjust it with liver issues. If they're Child-Pugh class B or C, you use the lower dose for erosive esophagitis, and you don't use it at all for H. pylori. I looked through the prescriber information from the manufacturer, and I don't really see it explained anywhere why there would be that difference. My guess for H. pylori would be that they did test it in combination with antibiotics you would use for H. pylori, and that did affect the concentration of the drug. So that would be my guess for the H. pylori side. I'm not really sure about the erosive esophagitis indication. I can't think of anything that would make it different. So I don't know what that is. If you find the answer to that, or if you know the answer to that, get in touch with me and let me know. There are important drug interactions with rilpivirine, which is found in medications used to treat HIV, and cisapride, which is a prokinetic that's actually not available in the United States anymore. Common adverse effects are really the same as you would expect from the PPIs. The ones that they list are upper respiratory infection, gastritis, abdominal pain, dyspepsia, paradoxically, high blood pressure, urinary tract infection, diarrhea, abdominal distension, nausea, and constipation. Of course, there's been a lot said lately about long-term adverse effects of PPI therapy, and all that still seems a little bit uncertain, a little bit dubious. We don't have real long-term safety data available for the new PCAB medication yet, but it stands to reason that if you're essentially doing the same thing as a PPI, but doing it more potently, that you would probably be prone to having the same long-term adverse reaction. So I would say it's still up in the air as far as solid correlations with this general kind of therapy and bad long-term outcomes. I did find an article by Bouzas from June of this year in Medical Hypotheses suggesting that maybe there would be a benefit to administering the PPI and the PCAB together if you really needed to block acid to treat these acid-related diseases. So I don't know that there's actually any role for that yet. And this doesn't really seem like a study as much as it is just sort of a, hey, what do you guys think about this? And I guess you could see maybe if somebody has like a gastronoma or an esophageal tear or a really bad ulcer that like you really, really, really need to stop the acid, maybe there could be a role for doing both at the same time. So that pretty much answers all my questions about this new-ish class of medicines available for treating acid-related problems. As always, I have no conflicts of interest or financial things to disclose. Although Fathom Pharma, if you're listening, hey, if you want to pay me for talking about this, I'm definitely open to it. If you have any questions, if you know anything different about this medicine that I failed to mention, feel free to get in touch. Thank you for listening to this week's episode. Special thanks to our Patreon supporters. Hope everybody's having a great holiday weekend, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Please be sure to like, subscribe, or follow on your preferred listening platform. Give us a nice 5-star rating and leave a nice review. If you'd like to help support the show, you can do that at patreon.com/knowledgeableprovider. And as always, stay safe, take care of yourself, and take care of your patients in that order.